Cool. Helen, are you ready? Shall we get started? Awesome. Cool. I will kick us off with the whakatauki. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai, e hi ake ana te atakura, he tihau, he huka, he hauhu, tihei Māori ora. Seize the winds from the west, seize the winds from the south. Let the breeze blow over the land, let the breeze blow over the ocean. Let the red-tipped dawn come with a sharpened air, a touch of frost, a promise of a glorious day. Welcome everyone to our webinar today about localities. We will be talking with Helen Parker from the Transition Unit about the model of localities, what it entails, why it's a crucial aspect of the health reforms. And it is a wonderful opportunity for all of you to ask your questions. Please use the question and answer function. As always, we already received quite a number of questions in advance from those who registered, so that's great. I will bring them into the conversation later. And those of you who have joined us for previous webinars know that this is part of a mini-series that we have run over the past couple of months. On the health reforms, we talked about the health reforms in general and made a case for the health reforms. Then we discussed the workforce charter and the health plan. And today we are going to talk about the localities. So thank you all for coming on again. As always, we are recording the webinar, so it will be accessible on our PSA website to all of you. Actually, it will be obviously public, so please do share it with your colleagues, with friends, with your whānau, if you thought it was interesting and useful. I'm aware that lots of you have to, work and struggle with rosters and, extreme workloads at the moment. So please tell everybody who couldn't join us today to just go online and watch it later if people are interested. There's also a wonderful website that was prepared and developed by the Transition Unit, which gives you heaps of information, specific information on the health reforms, but also specific information on the workforce as part of the reforms. So do check it out. It's the Future Health website. If you Google it, you'll find it. And I'm sure one of my colleagues will post a little link in the chat as well. So it's very useful if you want to check it out. So I think we are ready to get started. One thing I wanted to mention is that all of your questions will get answered, maybe not in the webinar, depending on how many questions we get and how our chat goes, but they will get answered afterwards by Helen. She agreed to answer the questions, and we will upload them to our website as well. You'll find the questions and the answers from the first webinar there already. The second set of questions, there were a number of questions, so they will be there very shortly. And you will find the question and answers for this one there as well very soon. Yeah, let's get started, I would say. Helen, would you like to introduce yourself before you give us a bit of an overview of localities, and then we get into the questions and a bit of a discussion. So yeah, tell us who you are.
Yeah, thanks, Andrea. Kia ora koutou, ko Helen Parker tōku ingoa. I'm really delighted to have this opportunity today, and I hope that we have a really interactive discussion about localities, because it's a real opportunity for us in the localities team to get feedback and help us in our future framing and development of localities. So I'm from England, as you can probably tell. My three children still live and work in London. I've been here for 8 years now, and was only coming over for 2 to do a distinct piece of work and then go back to England again, and I'm still here. And our kids say, surely you're 2 years up by now. But you know, we love it here, and Aotearoa is our home now. I've been working in healthcare since I was 17. In the English public health system. So I became a nurse. I see from the chat that there's a few fellow nurses. I did a lot of hospital nursing, and then I went into primary care. And that's really where my love of primary care and community services came from. And I've been in that field ever since, which is about 35 years. Once I left clinical practice, I went into the NHS management of primary care and community services, and was a director of community services and nursing for quite a long time. I then went into, I had a bit of time in the private sector, but then I quickly came back into a more public service environment. And I went into academia and did quite a lot of work on teaching, research and evaluation of healthcare models and health systems internationally. And actually that then led me on the path of being a bit of a health policy and health system nerd. I'm really, really interested in how health systems are designed, how they are organised, and what impact that has on the different actors, and particularly on whānau, families and individuals, and also some of the unintended consequences of health system design and policy. Hence why I'm delighted to be in this role we're now in Interim Health New Zealand, because it sort of plays to my provider health policy background. So I'm really delighted to be here.
Well, we are delighted to have you on. So thank you so much. That sounds really awesome. Actually, quite a bit of experience there that you can bring to the role. Do you want to open your presentation and give us a bit of an overview of localities and where they sit in the overall health reform? And then, based on that, we'll have a bit of a discussion afterwards. While Helen is presenting, please use the question and answer function and post your questions. If you can keep them nice and short and concise, that would be amazing. But comments are, of course, also welcome. Please use the chat function for that. So let's get started.
Okay, let me start again. Whilst I'm doing that, what I was going to say is that the localities element of the reform is a little bit different from the other areas of the reform, because actually it's building on developing what's already happening in communities and in localities as such. The providers are delivering care, communities are experiencing care. There are areas that have really developed some collaborative working, and the localities area is building on that. So unlike fixed points of system reform, like establishing the Māori Health Authority, establishing Iwi-Māori Partnership Boards, establishing Health New Zealand, our programme of work is really about continuing to develop some of that locality work already. Now, just give me 2 minutes, because for some reason. So I think, yes, and I'll talk about this a bit more in the slides. I think obviously, and what we need to be really clear about is that the current way of delivering primary care and community services is not working for large groups of people. So we need to be ensuring that within the reform and the transformation of the locality approach and framework as set out in the reform, that we are doing something new that's going to bring about different outcomes. So I just want to be clear about that. But we're doing that within the context of providers are already in primary care and community services. And so and a lot of areas are already doing quite a bit of work with communities to understand how communities want services are delivered and responding to that. And we're building on that. So the prototypes, which is the first tranche of localities, we've identified those using a number of parameters, and particularly around where we want to start to see some changes in health outcomes sooner rather than later. We've identified areas that have already done quite a lot of work in terms of collaborating with other providers, other sectors, and therefore building on that in terms of generating some learning for the future rollout of localities. But I'll talk about that now that we've got the slides.
That's right. Fantastic. Thank you, Rachel and Catherine in the background. That's wonderful. So Helen, the floor is yours. Give us a bit of an overview.
Yeah, so if we can just flick to the next slide, and this is the problem with this. Thank you. So for those, and I noticed in the chat that some of you are new to New Zealand or not, might be ingrained in the detail of the health reforms of some of us are. The minister announced some key system changes that the reforms are intended to deliver, and these run right through how we're developing the framework for the development of localities. And the first really important one is actually the health system has got to reorientate itself to delivering on the Te Tiriti or Waitangi principles and obligations. Number two is that identified in the Health and Disability System Review, it was although we already knew this, but it was really emphasised that across the country, the services that people have access to and the services that people pay for or don't pay for, there was huge variation, and we needed to do something to address that. So for example, in some areas they fund mental health practitioners, they fund clinical pharmacists, they fund physios or occupational therapists or social workers to sit around, particularly around primary care teams, and in some areas they don't. So one of the things that we're doing as part of the reforms is starting to reduce that variation and setting out some core services that every community will have access to. And this is particularly relevant to the primary care and community services. And then it also applies to high quality emergency and specialist care as well. I'm just going to be covering the primary care and community services aspect. What we also know, of course, is that New Zealand has been relatively slow on digital and data technology reform compared to some other countries, and some of that is around infrastructure to support digital and data healthcare. My caution a little bit is these are great. They have to be implemented really well and are not the panacea to every problem that we've got within healthcare and equity. And if not implemented well, it can actually increase inequity rather than reduce it. But we absolutely know that data and digital services are going to be critical to the transformation of primary care community services and how communities and services work together. And therefore, of course, this is obviously dear to me as being having been a provider within a health system, is we have to ensure that we've got the right workforce in the right places and that they are well trained, and I would say really well cared for too, who's looking after the carers. So there's some of the key system changes that we need to see, and it's informing a lot of, as I say, what we're doing around the localities. So if I pause, that's when I need the next slide. Thank you. So this is an image that gives an overarching visual concept of what we mean when we're talking about localities. And I say some areas are doing this to some extent. Some have got a bit further to go. So we're absolutely wanting to reorientate the system to a community, the whānau, individuals that are living in that community. And as we all know, actually, they look after themselves and their health and well-being for a majority of the time. The interaction and care that they receive from mainstream services particularly is actually quite small. And part of the locality approach is building on the strengths and the assets within that community and building up from there. I think one of the game changers around localities and that the whole process of locality planning is then taking the community and everything else that impacts on community well-being, like the Moriora lifestyle determinants of healthcare, and also Waiora, the impact of the environment and the local environment on health and well-being, and including those aspects in the locality plans. And then we come into the sort of more mainstream health services. And so what we're saying in the locality approach, we really need to strengthen the connection and integration between primary and community services, the hospital and specialist services, but also the social agencies that sit in and around communities supporting health and wellbeing, particularly agencies like MSD, local government. We need to be making those connections much stronger, and those connections and how that plays out within a locality will be a core feature of the future locality plans. So just to clarify some areas around what we mean when we're talking about localities within the reform. Localities will be defined geographical areas for the purposes of planning services in response to community aspirations and community priorities. So it's really a planning unit. It's not a population funding unit. And we do know that in some localities, there may be more than one community or communities that people identify with. Mm-hmm. The locality approach that sits on top of that is really what I've just been describing, is about communities determining how care needs to be organised and delivered to meet their needs, and therefore how providers respond to that. And a really great example that we've had, haven't we, in the last 18 months or so, is how communities have mobilised in response to COVID. You know, where communities have got together with agencies and providers to work out the best response for that community in some areas. And really that typifies the locality approach. And some of that approach and some providers may span more than one locality. But what we want to do and aiming for is that close to the community as possible, that the planning of how services are delivered happens. Now we're taking a sort of benchmark 20,000 to 100,000 population for localities. It's not set in stone. It will be locally defined with Health New Zealand and the Māori Health Authority as to the actual locality geography. So we may get some, a couple out of that. One of the reasons for that is if you try and take a locality planning approach and service delivery approach to populations less than 20,000, you start to struggle for a lot of services to have a viable population. If you have a locality that's more than 100,000 population, what the evidence tells us, particularly around how communities work and operate, is that people then struggle to identify with a locality. It's just become too big. And also providers, they become such a large provider network within that locality that they lose the relationship that, as we know, probably really drives how effective services are. So it's really difficult to develop those provider relationships if you get too big. And as I said earlier, every locality will have a consistent range of core services for that community based on equity and the needs. Next slide, thank you. So there's 4 essential organising systems that are going to interface and will need to interface with the locality approach, particularly addressing those more social determinants of health and driving a population health approach. And what we mean by that is actually, and there will be need to do some work on this in terms of developing the systems that support it and where we pull data from, but absolutely driving down to a population health data analytical approach to what's really going on in this community. What are all the sources of data telling us in terms of health and social care need, and then providing cohesive and accessible services through integration across these 4 domains. So the primary and community service provider networks, public health, of course, is really, really important. And then the vertical integration with hospital and other tertiary services, and then horizontal integration out, as I described earlier, with other social care agencies. So I'll just say a little bit about locality planning, because again, I think this is one of the things that's going to be really different in the new world compared to what we've got already, and will start to drive the change in outcomes that we need to see. And it's this process of from the bottom up, communities and the Iwi-Māori Partnership Boards are going to be critical in this, in ensuring that the priorities of Māori are written into those locality plans, that from the bottom up, the priorities and how people want services delivered will be clearly articulated and planned probably for about 3 years. And then the locality plans will be aggregated up to a sub-regional and regional and then national level, which will inform the commissioning and investment of services. Equally, the locality plans will also set out how the locality wants to deliver the elements of health service and healthcare that will be set out in the New Zealand Health Plan. So it's a bit of a top down in terms of this is the national framework for health, but very much translated into a locally sensitive way of delivering primary care and the community services.
Helen, do you mind explaining what IMPB stands for? You use it throughout the slide,
yes,
and
sorry.
Not everybody might be familiar with the acronym.
No. So written into the Paiora Bill is the establishment of Iwi-Māori Partnership Boards, which will be a formal entities, and I think there's going to be about 15 across New Zealand that will influence and work in partnership with Māori Health Authority and Health New Zealand to ensure that we are delivering on the principles of the Te Tiriti o Waitangi, the treaty, but also that the services and the planning of services and the commissioning of services is absolutely meeting the needs of Māori and addressing health equity.
Right, thank you.
Good question, Andrea. So just talk a little bit about some of the network services, the network providers. So what we do know is that in most communities you'll have community primary care teams. So typically you have your general practices, you'll have some community nursing, some allied health, you'll have your community pharmacies, all those sort of services that we're including in the what we're calling now the comprehensive primary healthcare team, midwives, so who work in that with the smaller population. We also have across the country provider networks that are focused on particular cohorts, so mental health and addiction, rangitangi, the youth, families and babies. You can see those on the slide. So palliative care. So there's provider networks that will span across localities because they're delivering care to particular cohorts of patients and people, sorry. And they will also obviously be operating across a continuum of care. So very much from a community delivery model right up into hospital, specialist and tertiary services. And part of what we're trying to do within the locality approach is make the connection between the primary care and community services and social agency teams with those provider networks. So this is just another visual, but it brings in some of the other elements. So as you can see, when we've put the comprehensive primary care teams, and they may be Kaupapa Māori teams, they may be Pacifica teams, they may be teams that are particularly working within rural communities. When you put those together with those priority cohorts, you start to build up hopefully a much better connected and collaborative response to community and locality need. Overarching that, as I said before, the whole population approach about us being really clear about what health outcomes are and where we need to, what the priority is for changing and turning the dial on some of those outcomes, but also the integration with, as I say, public health services, hospital and social services, but particularly around an emphasis on lifestyle and behavioural change. So starting to reorientate the system, and some areas are doing this already, around the prevention rather than treatment. So let's try and support communities to stay well, stay healthy, and some of that by taking action equally on some of those environmental factors. And I'll talk a bit more about that with the prototypes, the first localities.
Annie asked a question about the inner circle. I think it was the left one on the last slide. Annie, I hope you were able to read that now. It's very tiny writing, but we will have the slides uploaded to our website as well later on. So you will be able to check them out later as well. So I hope you were able to read that on the slide. Yeah, Helen, just continue. Thank you.
Yeah, absolutely. So there's some core elements of the locality approach that we're building into all the work that we're doing around supporting localities to start developing their plans. And these are the 6 core elements that have been identified that we need to really tackle if we're going to see those system shifts as a result of reform. So one is obviously the partnership with Māori through the Iwi-Māori Partnership Boards and the Māori Health Authority. The social determinants are absolutely critical, as we know, about making a much stronger connection between how we provide, plan and commission and invest in care together with those that are also doing the same around some of those social determinants and just working smarter. The integrated service delivery is obviously, but also enhancing some models of care. And I think this is where there's real opportunity. I do see huge opportunity in these reforms for communities and providers within a locality to have really good conversations about what's the art of the possible. If we haven't got the constraints of the old system, if you like, if we can remove what we know inhibits us all delivering health and well-being and good healthcare for people who need it, what would that look like? What would different models of care look like? And as I say, we've started to see some of this through some of the response to COVID. I've talked about the data and digital. That's going to be a real critical element, as is the community engagement. And one of the things we're going to be testing with the first tranche of localities is what models of community engagement are really producing effective results in terms of the community being really empowered to influence how care is delivered, and what new models emerge. So we're expecting some of these provider networks to do a number of things. I'm just going to highlight. So the first one, and emphasising is the obligations to the treaty, and particularly the sustainability of kaupapa Māori service options and approaches to delivering te ao Māori approaches to care. The population health approach is going to be really drilled down to a provider and community level. And I think for providers, this is also an opportunity for them to really understand, maybe for the first time, and to have access for the first time to a whole range of population health data. Some people do and some people don't, and making connections between different data points. And we're doing some work to say, can we get some quick turnarounds to be able to enable that data sharing platform, accepting that there's some privacy implications within that. I think they'll obviously, in the locality plan, is going to have to set out how the local health and social care system is going to address equity. I think the two game changers may be, when I say, what's going to be different about the new way of working to the way it happens now, is new models for new approaches to commissioning and contracting for those comprehensive primary care teams and the provider networks, which actually, and we know this from a collective impact, those of you that are familiar with a collective impact approach, one of the elements that really can drive better outcomes and having a positive collective impact is where providers and agencies have got shared outcomes and objectives that they're all working to, all understand, and are all held and all have similar accountability for. And we know that's one thing that can start to drive collaboration and integration. And equally, having common service requirements, priorities, and reporting and monitoring processes. What we do know now is that many services have siloed contracts. They have very different reporting requirements from other services that they work with. And that all helps to drive a fragmented system. So one of the things that we will be doing is bringing all that together. I just want to say a little about that. There is an acknowledgement, of course, that for a lot of people delivering health and social care, they're really, really busy. Most of the day is spent providing care to whānau and individuals and communities. And a key element of the locality approach is us enabling through policy and contracting and investment for providers to have time, protected time, to sit with listen to communities, work with communities, but also with each other, have time to build relationships, have time to talk to each other. How could we work differently? And we do acknowledge that is something that needs to be built into the reform process. I've only got a couple of more slides now. So where are we up to? Well, we've the first tranche of localities are going to be the first cabs off the rank, if you like. We're calling them prototypes for that reason, because they will be the first. However, what they will also be is the sort of testing ground to help us refine and develop the locality framework, and particularly the policy framework, as we move forward. So there has been some funding put in to support the prototypes to do this. We've done over the last few months, we've been doing some work in the transition unit to understand what's happening across the country already. What are areas doing that already play to the locality approach? How far are we as a country in moving to or already delivering this way of working? We know that because we want to test the locality approach, and particularly around understanding what works and what doesn't work, we want to have one in at least region. There'll be 4 regions in the new health system. We want at least one prototype in there. We want one prototype that's serving a high Māori population, and that's potentially Iwi-Māori provider led. We want one that's serving a high Pacific population, one that's in a rural community, and at least one that's in an urban area with a high level of deprivation, so that we can get a real breadth of learning, and that they're covering all those priority population cohorts. And then we've also done a bit of work to look at where do we need to turn around the health outcomes, where do we need to turn that dial sooner rather than later. That's provided us with about 19 areas across the country that could be potentially the first locality prototype. So we're just working with those areas at the moment to support them to develop a proposal to say, actually, if we were a prototype, what would we be thinking we're doing? What would be the priorities of this community or this locality that we would want to work on first? And actually, what are the things that we'd really, really like to change and test in a way that, you know, we could do some things differently if we could change this, and that we can then work with them, share the learning across the country, and it will also help to inform the future rollout. We do know, of course, that just because we've got the prototypes, that there will be areas in the country that will continue to develop the locality approach as well, and we'll also be learning from them. We're hoping to establish those the final selection will happen in late February, early March, and the prototypes will be formally established at the beginning of April. So exactly what are we prototyping? Well, really, it comes back to in a general sense, what I was saying earlier about what is the art of the possible. If we take a view in a community and a locality, and going back to there may be more than one community within a locality, what if we could do anything that we felt what does better look like? And if only we could do this, if only we hadn't got this system constraint, if only we'd got more access to this, or if only we didn't have this operational policy or this regulation of this profession or this way of working, we could do so much better. We want to test that sort of thing. We want to test what does a scaled up data and digital offering to communities look like. We want to test what does commissioning look like to support localities? What does the relationship between Iwi-Māori Partnership Boards and localities look like? What if you take an intersectoral collaborative approach to planning and delivering care for a community? What does that look like? What are other agencies doing in that locality? And actually, could we work smarter together? And of course, some areas are doing this, but we want to really push the boundaries on this. And of course, you know, innovation around actually care models we want to test as well. So we'll be capturing the learning, we'll be capturing what works. And actually, if we manage to break a problem and create a new solution that can be scaled up, then equally we want to share that learning and scale it up as quickly as we can as well. So I think it's quite exciting. It's challenging, and we appreciate that. You know, we're expecting a lot of the first tranche of localities to be doing this when we're actually in the middle of managing a pandemic. So we're absolutely cognizant of that too. And then my last slide, just to give you a view of the process. So we've done that stakeholder engagement and identifying those 19 areas. We're working with those areas to develop proposals. They'll be selected, as I said, late February, early March, and then they'll be established early April. Then we will be doing tranche 2, tranche 3, tranche 4. So as you know, well, in the bill, all the country will be covered by localities by the 1st of July 24. So there'll be a phased rollout of localities we go, and we're going to establish a locality learning system, so that we can share learning, not just from the prototypes, but from others, so we can make sure that what we've learned and what works is shared very quickly across the country. I think what will also come out from the prototypes and tranche 2 and 3 is what are those things that are common that we need to address at a national level. Now, I'm sure some of you will know what some of those are already. There may be, you know, how things are funded, as I say, how professions are regulated, that we're not going to be able to solve overnight, but we start to identify these are things that are actually going to have to be addressed if we want to see the changes we want to see. So I hope that's given you a flavour. I know it's a lot of information in a very short period of time if you're not familiar with this at all. So I appreciate that. So I'm happy to take any questions about any element of it at all.
Wonderful. Yeah, no, thank you so much. That was a really thorough overview. And I just wanted to ask a few questions from those who posted them prior to the webinar. You touched on some of the elements already, or some of the questions, but we got a lot of questions about the boundaries of the localities. And I think you mentioned there will be 4 regions and 19 localities. Is that correct?
No. So there's definitely four regions. So no, we've currently identified 19 areas in the country that are already doing a fair bit of this work.
I see.
That could be the potential prototypes. And I think, but the issue around boundaries, is for planning purposes, so that communities and the boundaries will be drawn by, you know, communities who identify as a community or as a locality. They're not boundaries for service delivery. And that's a really important distinction to make, because it doesn't mean that, well, if you don't live in this locality, you won't be able to access this service. Absolutely not. Because as we know, many provider networks, you know, take palliative care, for instance, or the mental health provider networks, they will operate over a number of localities. So the boundaries are not about service delivery. They're about communities having a voice and an influence about how they want services delivered to them.
And that possibly means that they don't match the current DHB boundaries. They will?
No, it absolutely does mean
they
that.
Won't.
Yes.
Yeah.
There's no requirement for them to do that. No.
We also had a question around the connection of the localities to the Iwi boundaries, if you like. Is that going to be considered in for the planning?
Or so as far as
brought in,
yes, as far as possible, there needs to be some coherence between localities and Iwi in iwi boundaries. It's not going to be always possible.
Right. I also was wondering, going back to one of your earlier slides, and I think that's a more general question, but we are trying to achieve a standard kind of approach to how we deliver health services, complemented with the local needs and the local kind of requirements that are necessary in order to give equal access and ensure equal outcomes. And I'm wondering how that will be moderated between the different, you have Health New Zealand and the Māori Health Authority, and then you have the localities. And you had that slide where, you know, you showed the cycle of how it will be working, but it's quite complex. Could you break that down a little bit and explain how that will work, especially, I guess, when there's conflict, when there's, for example, a standard a feature that is supposed to be implemented across the country, but a certain locality might not find that is a priority for them. What is happening in that scenario?
And I think that's where the, you know, a national picture, but actually it's operationalized at a very local level. And I think critical as well is what I was saying about the locality planning and the process of the different elements of a locality. So the community, the Iwi-Māori Partnership Boards, and the providers themselves and other agencies, you know, like local government, setting out in their locality plan what's priority for them. And I say that being fed upwards into the commissioning and investment plans at a sub-regional or regional level. There's always going to be that tension. I think it's not in my gift to say, you know, how conflict is going to be, any conflict is going to be addressed. But I mean, you get those tensions in any health system. I think the opportunity in this reform, and we really, you know, we're really going to have to grab it, I think, and you know, I think that's going to require it's going to providers who have worked in a certain way for a long time, who are trained in a certain way, you know, some of that cultural change in custom and practice, particularly in I think clinical services, may take time to reorientate to responding to how communities want services delivered. And as I say, we're not starting from scratch here. There's you know, in the discovery phase where we went out and looked what's happening over the country, many areas are doing that to some extent already.
We did have a number of questions around local needs and how they are actually, you know, defined, or which kind of needs are prioritized, how they are going to be assessed. Can you say a bit more about that?
Yeah, so that's that'll be around the population health approach, by absolutely being grounded in what is the data telling us, you know, and not just health data, but actually data that comes from other agencies too, and putting that together to form a health, whether, you know, a health needs assessment at that locality level. You know, which health outcomes are poorer and we need to turn around and focus on first. And that may be different for different localities. There'll be some localities where the themes may be similar.
Will that involve the voice of people and communities as well? Because data in the health system can be quite patchy. And
yes.
I think, you know, part of the reforms is also to, you know, acquire better data in order to do better planning and be more strategic about things. So I would imagine that involvement of the people on the ground, potentially including workers who are delivering the services to the people, who know what the needs are in a particular community, in a particular workplace, or a particular area. You discussed those beforehand as well, might be quite important. And how would that be delivered? How would the voice of communities be integrated into defining those or making those assessments of what is important?
And this is the importance of storytelling, isn't it? About listening to people's stories. And I think, you know, as I said before, I think that part of the prototyping is what works really well. And actually, does it work really well because of this particular history and context of the community? Or is it something we should be rolling out as part of the framework for localities? And as I said, you know, one of the things that we'll be testing with the prototypes is what models of community engagement really work.
Yeah, thank you. You also talked a little bit about you know, what we should be doing, or what we should be adding to the current work that is done within localities and communities. And you highlighted the importance of shared outcomes among providers, and you know, the idea of common network contracts, I guess, and new funding arrangements for those providers to do things differently. Because currently, I guess we are operating in many areas in a competitive environment. And how would these new or standard contracts and new ways of funding enhance that cooperation that seems so essential for localities to work? Could you talk about that a little bit?
Yeah, so I mean, and we haven't got all the detail around that yet. And as I said, you know, my slide around prototypes, this is exactly the sort of things that we want to test. Is let's understand what we need to change first, and then what the system processes and infrastructure, what needs to change to enable that to happen. But what we do know, you know, there's a fair bit of evidence out there already about what incentivizes and facilitates different ways of working. And it's not all about investment or funding or contracting models. Sometimes it is about people just having a common agenda and a shared understanding of what we're all working for. So having that shared outcome framework, and if you're codependent on each other for the delivery and success, then we know that facilitates collaboration and integration, as opposed to where we've got in some areas where people have got very different outcomes, contract requirements, reporting requirements that then inhibits that.
Yeah. I think it would be really interesting for our participants on the webinar to hear a little bit more about one of the pilots or the case studies that you're doing that inform going forward and identifying best practice. And maybe you have you know, some examples there where people are working well together on that local level, and where where things are delivering equal outcomes to the community, equitable outcomes to the community. Is there anything that you can share in that area? Maybe particularly in the urban space, because we got some questions about, you know, how that will work when you have huge distances to cover, you know, specific needs and, you know, limited resources. So I think that would be really interesting to hear a little bit more about that.
Yeah, I mean, I don't know if I can give you specific examples in being able to understand the detail about some areas. I mean, certainly what we've done with identifying the areas, and they're not pilots, they are the first localities within the reform system, is that many of them had already established and have got established collaborative ways of organising themselves and planning how services should be delivered and what better looks like, and not just within healthcare, but as I say, with Iwi or with Pacifica in those areas, and with local government and with other agencies. So that there's certainly areas where that level of collaboration in planning and delivery of services is happening. I think it'd be fair to say across the country, I don't think anyone has cracked equity. You know, we've got a lot of work to do on that. And of course, that's a big theme, if not the theme of the reform. So I don't think I could highlight one area particularly that's doing better. The urban picture in localities, you're right, it's quite complex. And we're doing a specific piece of work at the moment to think through what does that look like. And we are, obviously people, where people live and where they work, for example, can be very different. And particularly in urban areas, you have people coming into an urban area to work and maybe enrolled for example, with a general practice where they work and not where they live, which is why it's important to understand that the locality approach is for planning for communities, and particularly for people that live in that community, but actually service delivery will span communities in a lot of cases. But the urban areas, and particularly Auckland, for example, I live in Kirikiriroa, Hamilton, is more complex. It's more complex to define localities for that very reason. So we're doing a specific piece of work on that.
Another aspect that is really important to our members, and I've heard that in several meetings and discussions that we had in the past, are the social determinants of health and how they are too often overlooked or dealt with or seen as an important factor in somebody's physical but also mental health. And you mentioned that the social determinants are an important factor within the locality approach. And could you explain that a little bit more, how that is, for example, housing and employment support, how that will be integrated into localities, locality plans and activities in a certain community?
And I think we've already got an example of this in the whānau ora, haven't we? Where the whānau ora approach to supporting communities absolutely take this approach where they're not just looking at a very siloed health lens. So again, I think we'll be adopting the whānau ora approach. I think in terms of locality planning, it's getting the right people around the table, the community voice and providing a platform for that, but also ensuring that those other players in that community, whether it's MSD, whether it's local government, whether it's NGOs that are targeting services to some of those social determinants of health, that the planning process is including the voice and experience and expertise of those. And as I say, we've got some areas that have already done that.
Thank you so much. I have several more questions here on my little sheet of paper here, and we have several questions in the chat or in the question and answer function that we couldn't answer because we are close to 1 o'clock. But we are looking forward to your answers later on, and we will inform everyone when those questions and answers, of course, will be available online. We are uploading them to the website. So thank you so much, Helen, for coming along and sharing some of those insights and concepts with us, because I think there's quite a gap at this stage of what people are aware of, what they know. And this really helped to give us a better understanding of where we are at and, what's going to happen over the next year. So not just will the localities be defined in July, but most of you will know that the charter engagement will start in February and will run until roughly April as well. So there are lots of activities next year in the health space that are going to take place where we will need active participation of our members and a strong voice from health and care workers. So watch this space, more is going to happen. But for now, I would just like to wish everyone a really good break. I think we all need a bit of rest, a bit of relaxation, a little bit of fun and aroha. So thank you all for participating, for making this happen. Thanks to all the helpers in the background, to the participants. And I'm sure we will run some more webinars next year. We will see how we go, but definitely watch this space. And yeah, thank you. I will just close with a whakatauki and end the webinar then. Thank you.
Can I just say, Andrea,
Please.
you know, if people, you know, we haven't got all the detail sorted, you know, we're still planning and designing, and if people have got some suggestions and thoughts and want to contribute, then if you get an opportunity to engage, please do, or send me an email. We can let you have my email address so that you can, you know, we can take advantage of your thoughts and experiences and expertise as well.
Absolutely, that would be wonderful. And I'm obviously available to everyone here as well. If you want to send me feedback for Helen, I can collate it as well and pass it on, or we can arrange for another meeting or webinar. So thank you, Helen, for that, for offering that. No te roro, naku te roro, ka ora ai te iwi. With your basket and my basket, the people will live. So thank you, everyone, and stay well.
Okay. Thank you.